Well, hi everyone. On this last day, I will give you an overview of the Swiss FHIR activities and the challenges we face in the national and international context. My name is Michaela Ziegler, and before I came to medical informatics, I was a physiotherapist. And for 4 years now, I've been working at ADIS as an e-health solution consultant. We are involved in national as well as international e-health projects and are committed to the implementation of standards. Also, as technical manager of HL7 Switzerland and lecturer at the Bern University of Applied Science, I try to push interoperability and FHIR. What can you expect in the next few minutes? As I mentioned, I will give you an overview of the Swiss activities, which also includes our electronic patient record. We try to align our national work with the international projects. Today, I would like to talk in particular about the CHE-Talk project, the e-transition of care in Switzerland, and present to you the challenges we have faced and the solutions we have found. Let's start with the national context. A central topic is the Swiss electronic patient record. What do we understand by this? The EPR is a personal collection of health-related documents. Via a secure internet connection, this information is accessible at any time, both for the patient and for the healthcare professionals. But the patient decides himself who can see what documents and when they can do so. Everyone in Switzerland can open an EPR. This is voluntary and free of charge. Under the federal law on the electronic patient record, inpatient facilities and newly licensed physicians are required to offer an EPR. It is voluntary for all other healthcare professionals and members of the public. In the Swiss e-health architecture, an effort was made from the beginning to work with existing national and international technical standards and recommendations. In this way, previous experience and implementations could be used. For requirements specific to Switzerland, some extensions or adaptations were made. So in addition to the IHE profiles, HL7 plays an important role. And in the meantime, FHIR makes up the big part. We will now take a closer look at that. With the graphic coming up in the next few steps, I will give you a compact overview of our FHIR implementation guides we have. We have the core profiles as a basis. Based on this, there are the FHIR exchange formats with different topics, and further we have IGs for mHealth, eHealth. We have specified the national specifics in the core profiles. The requirements for FHIR documents, which is the basis for the EPR exchange formats, are also represented there. In addition, we have a terminology guide for the EPR terms, including translations into all our 4 languages. And the exchange formats are then based on the base profiles and are domain and use case specific. We have mapped medication, vaccination, immunization, and allergy intolerance. Further, there is a basis for order and referral by form, which is then used for transition of care, RED and lab order. In the EPR context, there are other IGs that describe how access to health document works, how privacy policies are managed, and how audit trail data is provided. All these specifications and more can be found at FHIR.ch. Now I will focus on e-transition of care and share with you the experience we have made in this project. The international project Structured Data Capture builds the foundation for CHORF, the definition of how we use order and referral by form as Swiss exchange format. Radiology and laboratory orders and e-transition of care are based on this. CHETOC is also based on another global project. The international patient summary is defined as a further dependency. CHETOC also uses elements from other Swiss exchange formats, including medication, vaccination, immunization, and allergy intolerance. Here we see another illustration of ETOC and its dependencies. CHETOC is a forum-based Swiss exchange format based on SDC. It contains a questionnaire and questionnaire response and a service request resource. The further document contents are represented in different sections. Where possible, profiles of the Swiss exchange formats are used, and the sections are based on the IPS project. However, the basis for the Swiss ETOC project is also the so-called EPOC report. EPOC is the Interprofessional Working Group eHealth, a group of professional associations of healthcare providers who are committed to practical data exchange formats. Many Swiss exchange formats are based on such EPOC reports. As you can see, there are many dependencies and also demands. In the EPOC working group, it was decided that ETOC should be based on IPS. During the development of ETOC, there were many discussions about how to cover all these different requirements. Therefore, after the first publication of ETOC, an evaluation was done to see if CHETOC is an IPS implementation. Similarities, differences have been identified on the project, document, and profile level. And it has been proposed what updates can be made to ETOC. The detailed report can be found at this link, and I will now give you a summary for the comparison on the project scope level and the outcome of the report. In the evaluation of the project scope, the following aspects were evaluated: the document that is exchanged, the intended use case, and the application area. What point in time and what data is mapped. Both documents, of course, contain information about the subject of care. IPS focuses on the essential information, and ETOC is exchanged as a forum with relevant information on a specific treatment. IPS is intended essentially, but not limited to, unplanned cross-border care, while ETOC is defined for interprofessional exchange during transition of care, whether planned or unplanned. In contrast to IPS, ETOC is focused on national use for the time being. It is used as directional communication between order placer and order filler, and as EPR exchange format. Both documents represent a snapshot in time. The data set is pretty similar, except for the difference that ETOC is condition specific, so it is in the context of a treatment. The IPS document is composed by a set of core data items indicated as IPS library. ETOC reuses, where possible, these data elements from the IPS library. However, it has additional elements specified by order and referral by form. Let's continue with the main findings. This report concludes by stating that CHETOC is not a base implementation of IPS, as it requires additional elements that are not necessary for the IPS use case of unplanned care. ETOC includes questionnaire and questionnaire response as a form-based exchange format. The service request resource for mapping the order, and in the case that it is used in the EPR, it requires a PDF. CH-ETOC builds upon the IPS library of content profile, and it's close to IPS as an exchange format, but there are different requirements for the free text entries. Another current difficulty is that the Swiss profiles, for example, for e-medication, are not aligned with those of the IPS. What can we do to make ETOC an IPS implementation? The report recommends a three-phase approach. First, bring the IPS requirements to CH Core and align the Swiss profiles to conform with IPS. Second, create a Swiss IPS implementation guide as an exchange format. And third, further align the CH-ETOC to conform with IPS in a future version. I'll show these updated steps again using the illustration earlier. Swiss profiles on resources that should be reusable within Switzerland should not be defined in derived implementation guides. Reusable resources such as medication statement or immunization should be defined directly in CH Core. Conformity with the IPS profiles should be specified in CH Core if possible. And derived implementation guides for the exchange format would then add additional profiles and constraints on resources where necessary for those use cases. CH IPS implementation guide should be created for the IPS exchange format, and examples could then there be added and also validated. In summary, it can be said that it is and will remain a challenge to reconcile national and international requirements. It was also recognized that even minimal deviations in the primary use case can generate differences. And finally, as I am sure we are all aware, harmonization can be a complex task that requires a lot of collaboration and consensus building. And I would like to finish with that today, and thank you for your interest, and hopefully we stay motivated and bring interoperability one step further. Yeah, you can reach out through these channels, through me, or I would like to talk to you about your experience you made, or happy to answer your question. And I'm really happy to be with FHIR here. He's the author of the CH-ETOC implementation guide and may support me with answering your questions. Thanks.
Any questions from the crowd? I see a hand already. Brilliant.
So Sheridan, I'm from Canada. We went through a very similar exercise following similar processes to you when we were deciding to look at how we would implement patient summary in Canada. I think our starting point was slightly different because we had looked at developing a guide with that patient summary scope off the bat. And so some pieces here are slightly tweaked from our approach. But what I'm curious about is if you have engaged the international community in supplying any of the places where you did find differences that you think are appropriate for how you want to see patient summary implemented in Switzerland, because I think that's a piece that sometimes as national iGuide authors we miss, is taking the things when we do these comparisons against international guides and bringing them back to the source so that the source can also be modified to work in our countries. And I think that's I'm curious if you've considered that as part of your next steps in this process, is bringing the things you think are appropriate changes to the international guide.
We did quite a detailed comparison on really on a element level in the resources, and I'm not sure if we considered that, but I guess if we have really some thoughts about that and we think it will be appropriate to bring it back, of course we will. Yeah, but thanks for your input. Yeah.
Thank you. Any other questions?
So regarding the differences, are they more in nature of conflicts or more in nature of further specifications?
At the moment, there are both, and the really main issue are the conflicts, of course, and this approach would be to resolve the conflicts. And yeah, we learned a lot over the last few years, and we really try not to be too restrictive, but the law sometimes needs that. So, but if it's not required from a law side or something like that, we not try to do that.
Okay, thank you.
Oh, I mentioned the e-medication. So we have there are kind of little conflicts with the cardinality that we can solve, I guess, quite easily. But then we use a different code set. So, and that's really on a national level and already in the industry. So I guess that's a kind of a thing we have to look at it and how to resolve it. Yeah.
All right, we've got time for one more question. Okay. All right. Sir.
Just a small comment, we participate in Switzerland also in this GDHB initiative, which wants to promote the IPS. And what we tried and what we had support for the government is that we tried our exchange format with at the connectathon, and it was quite good actually. I have some minor differences. I think we have more the problem that we started earlier than the IPS, and we are now in the process. How can we get compliant with the IPS? So I'm looking forward to the session this afternoon about national profiling, and we need to try to convince our government that we are involving stronger in this GDHB setup. So that was also, I think, one of the outcome of the report.
Thank you very much. Unfortunately, that is time on this session. So one more time, and y'all have a great day. Thank you.